Good morning, ladies and gentlemen. I warmly welcome you all to another CPD webinar session organized by Shri. First of all, let me remind you of the housekeeping rules. The webinar link will be available from 9 to 9:45 a.m. for everyone to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCC PD guidelines. These rules are there to improve and maintain the standards of the CPD programs conducted by Shri. I would also like to remind you all to keep your mics muted and videos switched off throughout the session. I thank you all for the strict adherence of the CPD regulations. Today, we are going to discuss a different topic, but something that is usually encountered by you all, which is regarding palliative care in a non-cancer setting. To discuss this important topic, today we have our country expert on this field. She is Dr. Udayangani Ramadasa, MBBS, MD, FRCP, FCCP, who is a specialist in internal medicine and head and senior lecturer in the Department of Medicine, Faculty of Medicine, Sabaragamu University of Sri Lanka. She is a product of Faculty of Medicine, University of Colombo, where she obtained the MD Medicine in 2014 and was board certified as consultant physician in 2006. She's trained herself in palliative medicine at the Sydney Institute of Palliative Medicine, Royal Prince Alfred Hospital, Australia, and obtained her clinical diploma in palliative medicine from the Royal Australasia College of Physicians in 2008. She is the chairperson of the Palliative and End-of-Life Care Task Force of the Sri Lanka Medical Association and Master Trainer in Palliative Care in Sri Lanka. She's also a member of the Interim Specialty Board of Palliative Medicine, PGIM, and also a member of the Board of Study in Medicine and Board of Study in Geriatric Medicine. She's a member of the National Steering Committee of Palliative Medicine, Ministry of Health, and life member of the International Association of Hospice and Palliative Care, and a member of the Asia Pacific Palliative and Hospice Care Network. Along with these positions, she has involved in many studies in the field of palliative care medicine and has won awards locally and internationally related to palliative care. Madam, thank you very much, and we are ever grateful to have you today at this discussion. Also, the time for questions will be at the end of the webinar. If any of you have a question, please type it in the chat box below and change your settings to all panelists and attendees. If you have specific questions about your situation, please email us on officeshri13@gmail.com. Without further ado, let us commence with the discussion. Over to you, madam.
Thank you very much for that kind word of introduction. And I would like to thank the Sri Academy for inviting me to talk about palliative care, which is palliative medicine, which is an emerging specialty in Sri Lanka. So today I'm going to focus more on palliative care in non-cancer setting. So first of all, I would like to ask you all, do you see death as a medical failure? So with this advancement of science and technology, we have seen that the people see death as a medical failure. So what has then Hippocrates said? So Hippocrates has defined medicine. It is to do away with the suffering of the sick, to lessen the violence of their diseases. So when we have a disease which we cannot cure, the relief of suffering is the cardinal goal in medicine. And that is the philosophy of palliative medicine. So we get patients with a lot of symptoms. What we do, we evaluate the symptoms and clinical science and investigations and other ways, and we come to a diagnosis. So some of these patients have curable diagnoses such as pneumonia, respiratory infection, urinary tract infection. And some of these patients has controllable diseases such as hypertension, diabetes mellitus, and some of these patients has life-limiting illness. Advanced heart failure, liver failure, cancer, advanced dementia, So this third category of patients actually challenge us more if we in our day-to-day practice regarding communication management, and we come to a stage where what can we offer, what can we do, how am I going to deal with this group of patients. So this group of patients, whatever we do from the time of the diagnosis, their functional level would deteriorate and ultimately they die. So during this period of time, they have physical suffering such as nausea, vomiting, pain, constipation, loss of energy, fatigue, and they have psychological suffering, and they have to face financial losses, loss of job, loss of relationship within the family as well as in the community and working places. And they become later on socially withdraw, and they might start thinking about life and what this life is, and the afterlife, what is death, what will happen to us. So suffering, spiritual suffering. So all these problems are real problems. They are suffering. So it's our duty to assess this problem in depth. And it is a kind of a care that we consider the physical, social, psychological, spiritual care all together as a holistic way. And it cannot be done by a single person of a medical officer or a physician. It should be a multidisciplinary team effort. So in 2002, the World Health Organization has defined palliative care as an approach to improve the quality of life of patients and their families. So this big diagnosis of a life-threatening illness is not just a diagnosis for that patient, and it is a diagnosis for the whole family. Sometimes it might extend to the immediate community as well. So the patients who are dealing with life-threatening illnesses. And we need to think about the prevention and relief of suffering by early identification, impeccable assessment, and it is a kind of a holistic care. We consider physical, social, psychological, and spiritual aspects of care. This is the definition of World Health Organization palliative care definition in 2002. So I think now you understand that palliative care provides relief of pain and other distressing symptoms, and it affirms life and regard death as a normal process. So it neither hasten nor postpone death, but it consider death as a natural event in these kind of situations. And palliative care offers a support system to patients to live actively as possible until they die, to improve the quality of life of these patients. And the palliative care offers a support system to help the family to cope loss of their loved one. So who is it for? The patients who have end-stage cancer, advanced cancer, and any end-stage organ failure like end-stage liver failure, renal failure, heart failure, and possible progressive neurological conditions such as advanced dementia, motor neuron disease, even advanced Parkinson's disease, and some other diseases such as advanced immunodeficiency syndrome, even the multi-drug resistant TB, and even complicated diabetes. That kind of diseases also has categorized under palliative care when they have come to the stage of life-threatening stage where we have very limited work to do the prolongation of their life. So when are we going to shift the gear to palliative approach in this broad category of patients? So when a patient is diagnosed to have a COPD, at the beginning in the diagnosis, that are we going to say that this patient is palliative? When a patient who has a heart failure, features of heart failure, at the beginning are we going to say? So it is a challenge in patients who are having non-cancer diseases. So when we introduce palliative care, it is a challenge and there is uncertainty actually when are we going to introduce palliative care. So anyway, initially good old days, even to cancer patients, actually once they try out with all possible curative care, and it is being transferred, the patient being transferred to the palliative care team for palliative care, where in day-to-day practice, when we say that we don't have anything to offer, we can't do anything. So that is the stage where initially we actually gave the palliative care, very good old days. But now we have identified very well that the palliative care, palliative concepts at the beginning of the illness, when you diagnose a patient who needs palliative care, and at the beginning of the illness, we need to introduce these concepts of palliative concepts. And it's true that at the beginning, we need to concentrate more on disease modifying as well as survival, the measures that we need to improve the survival, increase the survival. But we need to incorporate the concepts of palliative care. And with time, the role of palliative care team would be more and more, and it would be more and more towards the end. And at the end, it will continue until death. So during the last period of time, it's basically, it's the role of the care of these patients lies with the palliative care team. And it will not stop at death. It will continue even during bereavement. So this is the better concept, and this is the novel concept of palliative care, integration of palliative care into the current healthcare system. So when we have a patient who has, when we diagnose the patient has a life-threatening illness, so we need to identify the palliative needs. So we need to identify the physical needs, psychological needs, social needs, as well as spiritual needs. And we need to find out what are the options available to relieve these suffering. So there may be several options concurrently. And depending on the individual patient's preference, patient's circumstances, we need to select the best option for each individual patient. So that is the very important concept in setting up goals of care. So the goals of care should be to individual patients. So it could be the main decider of the goal would be the patient and the family members, and the physician and the multidisciplinary team would help and would explain them the possible options and the outcome of all these options and then then ultimately whole team would decide what are the goals of care. So we are dealing with patients who have multiple losses. So this is the stage where they understand, they realize that they have very short time to live. And some of them will lose the capacity of work. Some of them will lose the social contact. Some of them will lose the mobility and independence. With time, any patient would face with losing the capacity to work, social contact, mobility, and independence. And most of the time in Sri Lankan setting, actually, there is loss of autonomy during treatment. So most of the patients are not being told the diagnosis, and they don't know what's happening with them, and they don't have any control over their life and their disease and their decisions. And the changes in the roles and relationships. So if a life-threatening illness being diagnosed in the breadwinner of the family, so what will happen to others? So their roles, what will happen to the role of the patient as well as the role of the family, other family members also would change. So changes in roles and relationship. When you when you will not be able to deal with your responsibilities, what will happen to you? It is some kind of a loss that they feel, and uncertainty about life, the time that they have spent, they have left, and uncertainty about the disease and disease progression, and uncertainty about the death, what kind of a thing that the death would be, and uncertainty about the death and the afterlife, and uncertainty about their loved ones, their finances, their other aspects as well. So we are dealing with patients who has multiple losses. So when we care these patients, we need to understand that we are dealing with human subjects with cognition, volition, communication, and giving and receiving love. So we need to understand the suffering is unique to each individual. So though it is physical, psychological, social, or spiritual, and we need to understand it is a dynamic, active process. So the patient's priorities and concerns will change with the changing of the concurrent disease process. So when we set up goals, it is not for life, right? So we need to reassess and reassess and reset goals with the progression of the disease, as well as when their concerns and priorities would change. So when we identify goal of care, so it should be prolongation of survival still that we are concerned. So at the beginning of a very advanced heart failure, for example, we say, but still we think about the progression of the survival. And one other good example, I would say, if a patient is diagnosed to have a motor neuron disease, now it is a life-threatening diagnosis. But if the patient only has weaknesses in the peripheral, in limb weakness only, and if the patient's respiratory reserve and the respiratory muscle has not get affected yet, and if the patient comes with with pneumonia and hypoxia who would need ventilation, so we can go ahead and ventilate and give antibiotic because the respiratory muscles are still functioning. So prolongation of survival also one goal, and improvement of function, symptom control. Symptoms are not only physical, social, psychological, spiritual as well, and bereavement support. So there can be several goals concurrent. The goals would change with the progression of the disease, as I said. So at the beginning of the disease, we concentrate more on survival. With time, it's function, and towards the end, we only concentrate on comfort. So depending on the patient's condition and the natural history of the illness, we have to anticipate the problems that the patient would face in the future, and we have to have an anticipatory care planning. So what kind of care? As I said from the beginning, it is a holistic care. And what is this model? So in this model, we have our patient. We discuss about the physical symptoms, losses, psychological symptoms, existential distress, and preferences and cultural religious beliefs. And the same thing happens to the family and caregivers as well. We have to think about the quality of life of family and caregivers as well, and their health status. They also have empathic suffering with the distress of their loved ones. They also face with the challenge of role changes within the family and in the context of the community as well. And they have to deal with the grief and bereavement. They also have physical, social, psychological, and emotional needs. And they also face financial and practical support problems. They also have preferences and cultural religious beliefs. And is that the only two groups? No, the healthcare professionals. So when we deal with these patients, we should, as healthcare professionals, we should have knowledge of the natural history of the illness, and the knowledge of the problems that they would face, and knowledge of the care, what are the options, what are the things that we can offer them, and the prognostication and the terminal care, and our attitude, and how are we dealing with stress and burnouts. We would have to face the stress and burnout of the patients as well as caregivers very frequently. And we should be skilled enough to assess and manage these patients. And the resources, what are we going to do when we don't have resources as we expected? And am I capable in working in a team? So that is so in the palliative care model, we have to strengthen up all three groups. So who involved in palliative care? What is this team that we are talking about? So there should be a medical practitioner, and there should be either palliative care specialist, where we don't have palliative care specialists yet, but the PGIM are developing the MD palliative medicine curriculum now. Probably we might be able to advertise this year, and the other specialists who are related, who are dealing with their whatever the disease, underlying disease, and the nursing officer, social worker. Social worker has to deal with these, find out their grievances and their family background, and their financial and other aspects. And the psychotherapist, physiotherapist has a major role with these patients. So when they, for example, in non-cancer setting, if the patient has breathlessness, and if they come with panic attacks and COPD, for example, so the breathing exercises, relaxation techniques, the if it is bronchiectasis, other chest physiotherapy, and the improvement of the proximal muscle improvement as chest wall girdle exercises and the breathing techniques. So limited pulmonary rehabilitation and limited cardiac rehabilitation, and occupational therapists regarding the physiotherapists regarding neurological disorders, as well as the occupational therapists regarding the elderly patients, as well as neurological patients with neurological disorders. How are we going to help them to improve their function? Psychologists, pharmacists, to deal with the dangerous drugs such as morphine, speech pathologists to deal with the feeding and the swallowing and the speech and the communication, volunteers. So there are a whole lot of people involved in palliative care, ideal palliative care setting. So this is the Sri Lankan model. So where can it be provided? So we should be able to provide it in any healthcare institution as well as in the community. The best place would be their home. So it should be interconnected and interconnected with the teaching and tertiary care hospital to the peripheral units, as well as to the MOH level and the community. So there should be referral as well as the referral back. This is what is there explained in the National Strategies Framework in Palliative Care establishment in Sri Lanka, if you read. And that is generally general introduction regarding palliative care. So what is the difference between the palliative care without cancer, beyond cancer? So these patients live more longer period, and they are very well connected to the healthcare team. For example, COPD patients, their GPs connected to their GPs, their primary caregivers, as well as their clinic or outpatient department, where they are very well connected. So they have a good ongoing relationship for a reasonable period of time. And so as generalists, we all should know the domains of physical holistic care, as well as the skills. We need to develop skills of managing these patients, dealing with these patients, communication with these patients, and identification of end stage and providing end of life care. So what are the barriers in barriers. So these are the barriers which have identified when establishing and integrating palliative care to non-cancer patients, non-malignant diseases. So the clinician, patient, or family discomfort on discussing palliative care. So still in Sri Lankan setting, still we are a little bit infant stage of discussing about death and dying and the palliative care with our patients. So previous poor experience with palliative care. When you have had discussions or some kind of a care before, and if you have had poor experience, as well as this is a new emerging thought and the concept which has come to Sri Lanka over last few years' time. So we all have a little bit low experience in providing palliative care. Uncertainty regarding the role of palliative care team. So what is the role? Even when I was working in Australia, when we were visiting homes, as palliative care community team, some of the patients actually they leave house from the back door. So when we go into the house, there is no one. So because they don't know what is the role of this palliative care team. Cultural considerations around discussing the death and dying, unclear triggers for referral. So when are we going to refer these patients? Limited clinician time, whether we have enough time to communicate and talk to these patients. Think about their, when we deal more with patients who are curable, whether it's worth justified to spend more time with the patients who are anyway going to die. Fear of taking away from home, lack of recognition of impact of symptoms on quality of life. For example, we think when the patient comes shouting about pain, we tend to give something for the pain. But the nausea, vomiting, constipation, the general unwell, and the fatigue. So how those symptoms impacted on the quality of life of these patients? Have we thought of these things? Patient fear of abandonment by their usual clinician. If we talk about these life-threatening diseases, and if we accept that this is a life-threatening illness, patients will feel that the physician will give up. A focus on diseases rather than the needs of the patient. So we always focus on the diseases and the numbers of the investigation and the oxygen saturation and all sort of things. So have we considered the need of the patient and the quality of life of them, and the limitation in availability of palliative care services? Though we talk about palliative care, have we established any kind of a palliative care service in any of our hospitals? So how many number of hospitals that we have the palliative care teams? So that is the general thing. So I have only half an hour left. So now we will start palliative care proper regarding non-cancer patients. So when we deal with these patients, we should know the natural history of this illness, which is called illness trajectories. Right. So this is the first group of patients, where the cancer patients, they have quite stable period of life, and they deteriorate within a shorter period of time with a lot of symptoms and suffering, and they die. And these are the two groups that non-cancer patients that we are dealing with. The patients who have organ failure like liver failure, heart failure, renal failure, COPD, they slowly deteriorate over a period of time with their function, as well as the physically they deteriorate, but there would be exacerbations, and this exacerbation might lead the patient to come to the hospital, crisis admissions. And either one of these exacerbations, there's a chance that the patient might die. So that is the natural history, the trajectory of the organ failure. And this is the group where we see in old age dementia, Parkinson's, and some of the neurological disorders, and they slowly deteriorate over a longer period of time. And there can be some incidents like urinary tract infection, pneumonia, or any other illness that the patient might face some depression, in the dips in their physical and other aspects, but they slowly deteriorate over a longer period of time. And either one of those, aspiration pneumonia or anything, a fall, fracture hip, would have been the reason for them to finally end their life. So that is the physical trajectory. So are we only concentrating on the physical trajectory? No, this is a holistic care. They have physical, social, psychological, spiritual. So the other trajectories also have plotted, right? So the physical and social goes hand in hand, but the psychological and spiritual, there's a very high, very significant dip at the time of the diagnosis. They try to cope up with the diagnosis after some time. Then once they return with a very big diagnosis, they become depressed back again, and then they cope up with that for a reasonable period of time, and when they face recurrences again, the same. So we need to understand, because these are the periods where you will get some grief reactions, and they will go for doctor shopping, and they will sometimes have some unpleasant discussions with the treating team as well. And this is the trajectory of the organ failure, where the physical, social, psychological, there are dips, but the spiritual aspect, there are fluctuations underlying in the baseline fluctuations. And this is the old age. So we have seen old age dementia, these patients are quite stable, though they have been deteriorating. But towards the end, they become more and more the all aspects, physical, all aspects, social, psychological, spiritual decline you might notice in these your grandparents towards the end. So it is not only the family that the patients have trajectories, the family also faced with similar, or they also have trajectories, which we should know. We should know these trajectories when we actually want to plan and deal with these patients. So how are we going to identify patients who need integrated palliative care? This is a very good way that you can guide the strict guideline that you can diagnose, you can identify which are the groups of patients who would need palliative care. And once you identify, you need to integrate palliative care to the current healthcare system. So we need to integrate palliative care. So it is something like integrating the prevention, primordial prevention, secondary prevention. So likewise, the palliative care also should be integrated into this natural trajectory of the illness. And there are few terms that I want you to understand: the palliative care, end-of-life care, and terminal care. So palliative care is the care that we give from the time of the diagnosis of the cancer until the patient dies, and even after death during bereavement. So end-of-life care is if you think that the patient have only months to live, not more than 1 year, then we call it end of life. And terminal care is the duration where the patient has diagnosed to have actively dying. So that is the the duration where we give the terminal care. So when we talk about end of life care, we again need to it is last months or a year of life. So it is a significant period of time, right? So we have to deal with these patients. So this is the prognostic indicator guidance gold standard framework, where you ask the questions, the surprise question. As a physician, as a clinician, you ask yourself, am I surprised to see this patient in 2024 Christmas, right? So, or 2023 Christmas, or 2024 January. So if you are surprised to see this patient alive, then that is the patient who you consider as end of life, the patients who has entered the period of end of life. So then you need to find out the general indications of decline as well as the specific indicators of this decline. So general indicators, we have to look at the disease activity and the comorbidities, general physical declining, increasing more and more support for the activities of daily living as well as the other activities like shopping and the activities at home, and whether the symptoms are becoming more and more complex and they are irreversible. Whatever the treatment that you give, you will not be able to control these symptoms, and there is no choice for any further active management for this patient. Progressive weight loss and recurrent hospital admission, serious fall. So those are the general indications, and we can check the functional assessment using our Barthel index. So the Karnofsky performance status, ECOG performance status, and the other assessment tools like ADL, activities of daily living. So with that, you can find out the functional deterioration, and you can monitor the functional deterioration, and we need to look at the specific clinical indicators. So for example, in COPD patients, the ejection fraction, these are the clinical ejection fraction, the breathlessness, whether the patient is short of breath after 100 meters on the level 0 or confined to house, symptoms and signs of right heart failure, recurrent hospital admissions, the surprise questions, the long-term need of long-term oxygen. So the heart failure, NYHA classification, stages 3 or 4, shortness of breath, recurrent hospital. So likewise, it is being defined, and which group of patients we consider them as has entered the end of life. So rarity, weakness, Barthel index, significant weight loss, exhaustion, stroke. When I was invited for this lecture, one of the clinician asked me, "Are you talking about stroke?" Not all the strokes are basically need rehabilitation. But if the patient has a very, very big stroke with ICH or any large infarction, where the patient would have ongoing deterioration, then we consider them as palliative, right? And dementia. When are we going to say the dementia has entered, the patient has entered end of life? So then the physical symptoms. So not only the cancer patients, the non-cancer patient also has physical symptoms. We have seen that they have short of breath, dyspnea, but have we noticed that they have pain due to immobility? Have you questions about the constipation, nausea, vomiting, weakness? And when we have these patients, we need to do a comprehensive assessment. So we need to find out the characteristic of the symptom, if it is pain or shortness of breath, the characteristic, and the meaning of the symptoms to the patient, because nowadays most of the symptoms are related to the COVID vaccine. So unless we in-depth question about the meaning of the symptom to the patient and the behavioral responses, the elderly as well as the children, they have bizarre behavior, but we need to, as clinicians, we need to find out what is the reason for that, and the contributing factors, relieving and increasing factors for us to deal with in the management. So in the management, we need to find out the underlying pathology. Say pathology, for example, if the patient has nausea or vomiting. So whether the underlying pathology is due to constipation, whatever you give, nothing will happen unless you give, treat the constipation. So if the patient has nausea due to increased intracranial pressure, unless you give steroid, it will not settle. So if the patient has nausea due to gastric stasis, so what you have to give? So likewise, you need to treat the underlying pathology. If the breathlessness is due to pleural effusion, unless you aspirate the pleural effusion, patient will have breathlessness. The change in the conception, sensation, and perception of symptom is very important. So why do we give morphine to improve shortness of breath? When they have refractory breathlessness, the drug of choice is morphine. Why? What is the action of it? So breathlessness is a feeling, dyspnea is a feeling that you are feeling breathless, right? So if we change the sensation of breathlessness in the brain, so the patient would become more comfortable. So change in the sensation of breathlessness is the main action on morphine to relieve breathlessness. Diminishing emotional reaction, optimization of function. So now you will understand from the beginning I said regarding the management of breathlessness, the importance of the pulmonary rehabilitation. So it is an integrated way of pharmacological and non-pharmacological, targeting the cause and the contributing factors. And we need to tailor according to the patient's beliefs, preferences, and circumstances. For example, if the patient with a COPD, according to the patient's circumstances, one might consider home oxygen, one patient might not a candidate for home oxygen. So likewise. And the next important thing is the diagnosis of dying. So that is one way that we all fail sometimes. So if you don't diagnose dying, we continue to give futile interventions. We don't talk about, so ultimately what happens is the patient will end up with very undignified, fearful death in somewhere in the ICU or somewhere with all these resuscitation and the, everything. So because of that, it is very important the diagnosis of dying. So for us to diagnose dying, we should know how to prognosticate, and we should know we should be able to recognize the dying. So what is good death? We all talk about good death a lot of times. What is this good death? So this is the word definition. Free from avoidable distress and suffering from patients, families, and caregivers, and reasonable, consistent with clinical, cultural, and ethical standards. What it means, what it includes. So good death is multidimensional. So it has several components. It has physical component, clear decision making. So we need to prepare the patient for the death. We need to allow the patient to complete their life, to say goodbye and complete their life and finish off their work and go. We need to find out that they need to contribute something to the community and others, and what are the things that they expect us to contribute to him. And we need to look at this patient as a whole, affirmation of a whole person. So the palliative care don't stop there. So it will continue after death as well. So the bereavement support is an integral part of palliative care. So grieving after loss is normal process. We all grieve. But if it seriously compromises the health of the individual, then we need to think of intervening. So these kind of patients and families has to be identified during the period where you give palliative care. So you won't wait until the patient die and identify the seriously these difficult grief reactions. So we can't forget that our loved one has gone, right? So we can't forget, but we need to integrate the grief and loss, and we have to live with that loss. So that is it. So just during this last 10 minutes, I would like to show you very quickly. I'll show you how this apply to our day-to-day practice. So this is a 79-year-old patient who was brought to the outpatient department due to refusal of food, deterioration and short of breath, disorientation and short of breath. He is a diagnosed patient with ischemic dilated cardiomyopathy with left ventricular ejection fraction of 15 to 20%. So cardiologist has suggested conservative management. So the patient has admitted with shortness of breath as well as some features of delirium. He had urinary incontinence over last few days and bowel had not opened for last 5 days. He has bilateral fine crepitations with one coarse crepitation in right side. That means he has features of heart failure as well as some evidence of possible aspiration pneumonia. So the abdominal examination revealed palpable matter due to the constipation. Rectal examination revealed rectum full of stools. The retention would have been due to the constipation. He was a patient with recurrent hospital admissions with heart failure. That means the patient has already reached the end of life phase. And in between shortness of breath, in between the period where the patient is at home, patient has some amount of shortness of breath to mild moderate exertion. I spoke to you regarding NYHA classification. And so his mobility was further limited due to pain in the hips. So that would have been the main reason for him to develop constipation, which has caused the urinary tract infection and retention of urine as well as the aspiration pneumonia and the delirium, right? So he had been living with his wife, who is very supportive, but socially, when we think about him, dignity of him, actually, what kind of a person he is. He's a retired school principal, and after retirement, he had been a very active person in the village, giving leadership in various social and religious activities. Now he is becoming more isolated, only watching the TV due to his hip pain as well as the shortness of breath, right? So in this house, there's a squatting pan. That is the place where the occupational therapist has to intervene, right? So it's basically the constipation, urinary tract infection, aspiration pneumonia, right? So is this patient palliative? Yes, according to the guidelines, the patient is palliative, and there are level 1A evidence that this patient need to be referred to palliative care. So what are the factors predict then increased likelihood of death? So these are the factors we should know. That is why I said when we deal with this patient, we should have knowledge about whatever the illness that we are dealing with. And so how are we going to give palliative care? So we need to assess, we should be able to prognosticate, we need to prepare the patient emotionally as well as psychologically, and we need to discuss about their preferences. We need to plan for the worst. So this is a case 2, COPD patients who had recurrent hospital admissions, feels very tired, and he developed panic attacks. You know, the breathlessness is a very fiery feeling. You feel like almost you are going to die and you are going to be choked, right? So what are the causes for death in COPD? Acute chronic respiratory failure, pulmonary infection, embolism, cardiac arrhythmia, lung cancer, right? Heart failure, right heart failure. So symptom burden, what is the symptom? Not only breathlessness, anorexia, constipation, fatigue, pain, anxiety, depression. So what are the prognostic indicators? As I showed you before, FEV1, MRCP grade, symptoms, recurrent hospital admissions, right? So, and this is very important trajectory that I want you to look into. Now, these patients, now they slowly deteriorate, and we have seen patients coming to the hospital with exacerbation and they recover and go, but they don't recover up to the level they were before. There had been ongoing deterioration. And there you might have noticed that towards the end, when they admit, if you inquire about how the patient has behaved, how is the patient's condition after the discharge of the previous hospital admission, right? So they might say the patient was breathless, very breathless. He couldn't get done day-to-day activities. Symptom did not improve much. Had to take salbutamol inhalers several times, and he didn't eat much, and he was not interested in talking and all. So that is the accelerated failure phase. And after that, if the patient dies, that is how we diagnose dying, that this is the time that we are not going to recover this patient in this admission. So this is one important aspect, not only the pain and other things. When we talk about the breathlessness, and it has a thinking component where you have anxiety, distress, panic, and the breathing component where you have breathlessness, bronchi, crepitations, and all those stuff, and the functioning components. They are becoming very, very anxious, as well as self-isolated, and decondition of the limbs and the chest wall accessory matter. So in managing these symptoms, we have to think about the pharmacological as well as non-pharmacological. So breathing techniques, handheld fan, thinking, functioning, pulmonary rehabilitation, walking aids, mindfulness, all those things. So pharmacology, if they are anxious, having panic attacks, we might have to give benzodiazepine. If they are depressed, we might have to give antidepressant. If they are breathless, might help with oxygen as well as the opioids. So how are we going to start opioid? It's a very small dose, 2.5 milligram 8-hour oral morphine, and you can increase depending on the improvement. And the non-pharmacological management, like breathing exercises, forward positioning, walking aids, and the facial cooling. This is a very, very, very useful, very simple thing, that if somebody is breathless, right? And the other aspects. So because it is just an outline of palliative care. How are we going to give palliative care in non-cancer setting? So I would like you all to look at this publication. If you go to the National Cancer Control Program website, there are space called resources, and under resources you have publications and handbooks. And in that publications and handbooks, you have the publications of palliative care for cancer patients in primary health care. And this is the publication from the Sri Lanka Medical Association, where palliative and end-of-life care task force, the palliative care manual for healthcare professionals in Sri Lanka. So each and every symptoms is being discussed. How are we going to manage? Even the itching and restless leg syndrome in end-stage renal failure, loss of appetite in end-stage renal failure are being discussed. And the system-wise, disease-wise, there are very good accounts that how are we going to deal, what are the problems you find in patients with end-stage liver disease, and how are we going to manage those patients. So likewise, you will see very good account on practical account on how to manage these palliative patients. And this is the practice guideline in end-of-life care. So how are we going to make decisions, and how do you communicate with these patients? And this practice guideline is developed according to the current Sri Lankan law, so common law. And so then if you go down, there would be pain management guidelines and other stuff as well. So what I would like to say to finish, I mean to at the end, that the quality of life will be, this is I quoted from the internet, the Kirk Ashley has said, the quality of life will be determined by the quality of your contribution. When you work to improve the life of others, your life improves automatically. So this is being tested, and this is being researched, and this is being found. When you deal with to improve the quality of life of your patients, and it will eventually improve the quality of life of your life, as well as the quality of life of the patients, caregivers, as well as the family members. Thank you.
Thank you very much, madam. Now we will go on to the question and answer session. We already have a few questions which were sent by the participants. The first question is, what are the strategies to prevent analgesic overuse in palliative care?
Yeah, so the palliative, first important thing we need to understand is when a patient is having pain, so you will not expect dependence of analgesics in palliative care. So if the patient don't have pain, if you give analgesia, they will develop toxicity. So the analgesic overuse in palliative care, to overcome those strategies, what in Sri Lanka we have developed, National Steering Committee have given with the Ministry of Health, and there are circulars where to commence morphine opioid in palliative patient. It should be consultant can prescribe for 2 weeks or even for 1 month. So the others can only give only for 3 days. That is one strategy that we have used. And the next thing is all these publication. And if you go to the National Cancer Control Program, lower down, there are management guidelines. So when we talk about, discuss about developing palliative care about 6-7 years back with the Ministry of Health. So they initially wanted us to develop guidelines regarding morphine. So if you read those guidelines, any one of you can actually look at the guideline. You will be able to safely commence medications, and you will identify the patients, the WHO ladder and the adjuvant analgesics as well, and how to increase the morphine, how to give breakthrough. So those are the measures. And the other thing that when we have palliative patients, actually, currently in the places, hospitals where we have started the palliative care services, there we have identified the pharmacist, and we count the number of analgesics that we give. And if the patient dies, actually, they have to return the rest of the medications. So that is also been monitored. Even in other countries, it's the same.
Thank you, madam. A second question is, what is the management of a patient who has high opioid tolerance, who is already on very high doses?
So if the patient has pain, if they are on very high doses of morphine, usually high doses of morphine are needed in patients who are having cancer. So if they are having very high doses of morphine, so we need to revisit. So we need to identify whether we have made the correct diagnosis of pain. Correct diagnosis of pain means whether there is any neuropathic component, whether there are any measures such as giving palliative chemotherapy to reduce the size of the cancer, whether there are any interventions that we can make by nerve blocks or anything. Whether we can introduce the adjuvant medications such as antineuropathic medications and steroids that will reduce the dose of the morphine that we need to give. And if the patient, for example, if there are, whether there is a place in radiotherapy, small fraction of radiotherapy, so that those are the things that we need to so the most important thing is we need to revisit. So why this patient needs this much of pain medication, and whether there are any other way that we can reduce the amount of the opioid that we are giving. So there are very rare instances that we have actually taken up all these measures till the patient needs high doses. Then we will have to give, because we have to keep the patient comfortable as much as possible.
Yes. Next question is, what are the palliative care centers available in Sri Lanka?
Yeah, so that is a very good question. And that is the question always asked from all of us. So the palliative care centers are basically established. Most of the cancer centers in Sri Lanka, most of the hospitals where they have cancer oncologists, they have actually started the palliative care services. So other than oncologists, some of the physicians who are actually interested and working for palliative care establishments like Dr. Dilhar in Colombo South Teaching Hospital, Dr. Gamini Patirana in HSL, and Dr. Consultant Neurologist. Dr. Dilhar is a physician, as well as he is one of the pioneer in establishing elderly medicine in Sri Lanka. And Dr. Ravini Karunatilaka, who is actually taken the initiation of introducing the management of breathlessness in a palliative setting in HSL. So the purely because of their personal interest, there are places. And other than that, the cancer oncologists, and there are Cancer Care Association and other, and even the palliative care association. There are community services. So with the general practitioners actually has got together and has come in these services. So those are I mean, it's vaguely, it's not very well established, but there are services. Yeah.
Right. Next question is why we need to prolong life when the patients are having terminal and continuous suffering symptoms?
So palliative care, I said as a concept, we neither postpone, prolong, nor shorten death. So it is not prolongation of life. It is not euthanasia, right? But I told you at the beginning, palliative care should be incorporated at the beginning of the illness. So especially in patients who have non-cancer and even cancer patients. If you consider giving, if the oncologist consider giving palliative radiotherapy and chemotherapy, it will prolong life. Though they have a life-threatening illness, they will prolong a quality life. So if you can prolong a quality life, so we would definitely go for that. For example, in COPD patients, right? If we can improve the quality, even though they have advanced disease, by giving some limited pulmonary rehabilitation and improve the quality of life, that is in a way that it might prolong for a period of time. And as I said, in motor neuron disease, I mean, if the patient has not, if the patient's vital capacity and the respiratory muscle function are still very good, so why don't we prolong? So that is kind of a euthanasia. If we just say that the patient is having pneumonia, this is a motor neuron disease, so you don't do anything, give morphine, and so that is not. So that is what I said. This is something that we need to integrate to the current healthcare system. So when we diagnose that this patient is actively dying, that is the period where we need to withdraw. Withdrawal of what is it called, the futile intervention. So the futility depends on the underlying disease condition, and whatever the intervention we do, we should be able to predict the outcome of that intervention to that particular person. So if the outcome is not accepted and not the best interest of the patient, that is the intervention which is futile, and you are not going to provide that intervention. So we should know what is the concept of futile intervention. So it always depends on the patient and the condition and the stage of the illness.
Right. The last question is, madam, what are the ethical aspects of euthanasia? And also this question was in the chat box. What is the place of euthanasia in a terminally ill patient? And what to do if a patient or family member asks for it?
Yeah, so euthanasia is not palliative care. What my opinion is, if we deal with these patients and family members And if we relieve their symptoms, not only the physical, social, psychological, address their problems, suffering, none will ask for euthanasia. Right? So why they ask for euthanasia? Because they can't cope with the suffering. So that is a failure of us. So if we have provided proper palliative care, no one will ask for euthanasia. Euthanasia is not palliative care. I recommend all of you, it's a very small book. If you just Google in the internet, you will find the guideline of end of life care guidelines that we have developed. It has been discussed with the legal department as well. So that is according to the current law of Sri Lanka. So it will give you very good account and why we don't think of euthanasia. What the palliative care doesn't mean to hasten or postpone death of a patient. It accepts as it's a natural event, and you will realize several different incidences, how you deal with these patients, how you make decisions on individual patients of yours if you read the end of life care guidelines.
Thank you very much, madam. If you have any more questions, you can email them to us. And also for the rest of the questions which have already been sent to us, we will get the answers from madam and get back to you. Madam, I would like to thank you again. Our sincere gratitude goes to you for spending your valuable time and for your excellent lecture. And as for the participants, we have posted the link in the chat box for you to complete and for you to receive your e-certificate. Again, thank you all for joining us today. Hope to see you again next Sunday for another interesting topic. Have a pleasant day.
Thank you.